Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features expert answers to healthcare provider questions surrounding treatment for patients with pancreatic cancer. This episode is part of a larger educational program titled Current and Emerging Clinical Strategies for Pancreatic Cancer Treatment. During this podcast, Dr. Michael Pishvaian from the Kimmel Cancer Center and Johns Hopkins University School of Medicine in Washington, D.C., and Dr. Rachna Shroff from the University of Arizona Cancer Center in Tucson, Arizona, discuss important topics including preferred neoadjuvant therapy regimens for patients with resectable pancreatic cancer, appropriate sequencing of therapies for patients with metastatic disease, and best practices in the use of targeted therapies. Please visit the show notes for this episode for a link to the complete program, including downloadable slide sets, expert commentaries, and an on-demand webcast from the live CCO event. Now let's get started and hear what the faculty have to say on these important topics.
Overall, I think it's important to consider that pancreatic cancer is a disease that we're making some clear improvements on. We've improved overall survival thanks to the chemotherapies. We've improved our understanding of the disease, and particularly the biomarkers of therapy, and that can lead to specific targeted subgroups that may benefit. But there's definitely still a lot of work to be done in this disease because we definitely have to improve more than overall survival of just 10%.
But Dr. Pishvaian, what do you think about when you see a patient in clinic and who should be getting neoadjuvant versus adjuvant treatment?
You know, I always tell my patients, as I'm sure you do, that pancreatic cancer is a systemic disease from the outset. And if we can get chemotherapy into them safely and kill any microscopic disease before they go to surgery, I think that we are doing them benefit. And that's what the New Alliance study will hopefully show us, or at least that's the leading hypothesis. But we also know from many studies that have been done over the last 10 years that about 30% of patients don't make it to the operating room for various reasons. And so is that a good thing that these are patients that are being quote unquote weeded out, or they're undergoing an oncological stress test, as some have said, and so they're spared a big operation when it wasn't going to help them? Or are they missing their window of opportunity? And we just don't know the answer to that. But as a general rule of thumb, I do offer neoadjuvant therapy preferentially for all resectable patients and certainly for all borderline and locally advanced patients.
Yeah, I would tend to agree. I think for borderline resectable, the discussions really center around which therapy, for how long, radiation plus or minus. But I agree. I think in borderline resectable disease, I feel very comfortable saying that neoadjuvant therapy is the right thing. And I agree. I think I have a tendency for resectable disease to discuss the use of preoperative treatment. And I agree. I think a lot of it has to do with the test of time and understanding the biology of the disease. And I say to my patients that unfortunately, if we miss our window for resection, or you develop metastatic disease as you're getting preoperative FOLFIRINOX or whatever we're giving, I mean, that right there says that you probably would not have done well on the other side of a surgery. So I tend to agree. Do you have a preference or a bias towards certain neoadjuvant regimens, or anything that kind of you feel is the quote right thing to do?
Yeah, I mean, up to the SWOG 1505 study, I definitely was favoring FOLFIRINOX, but I think that Dr. Sohal's study really made it crystal clear that the gem-nab-paclitaxel combination is just as good, or at least there's not one that's clearly better than the other. So I still use patient selection the way that I do for patients with metastatic disease that I know you're going to talk about. But I feel much more comfortable when I choose to give a patient gem-nab-paclitaxel that I'm not withholding quote unquote better therapy from them.
Yeah, I agree. I think SWOG 1505, it's funny because people are saying, oh, it didn't really answer the question, but I think in some ways it did. I think it made us feel more comfortable that perhaps both of our quote unquote standard metastatic regimens are reasonable, and you know, patient by patient, we can make those decisions. What would you do in terms of a therapeutic strategy? So when you think about sequencing in advanced pancreas cancer, you know, if you use a gemcitabine-based regimen like gemcitabine and nab-paclitaxel, then the data could support using Naliri with 5-FU leucovorin in the second-line setting, given that there is the NAPOLI-1 data after gemcitabine-based therapy. modified FOLFIRINOX, well, then you've used a 5-FU regimen, and so then the Leary data is not the relevant data. And here, then, we tend to use gemcitabine-based treatments with or without nab-paclitaxel. Here, after Leary, you could even consider moving to an oxaliplatin-based regimen like FOLFOX or CAPOX in the third-line setting. So it kind of gives you a third-line option, if you will. There are a couple questions related to BRCA-positive disease, and so I thought we could start with those. And it's really asking the question of, in a known BRCA-positive patient, do we think that cisplatin has more benefit than oxaliplatin? So, the question of, are all platinums created equal? Dr. Pishvaian, do you have any comments on that?
Yeah, I think the answer is we don't really know. There definitely are preclinical studies that have suggested that cisplatin is more potent, but in true patients, we really don't know yet at this point. And so I would say I would feel very comfortable using either an oxaliplatin-based regimen or a cisplatin-based regimen. I'll use this opportunity, though, as a segue to plug Dr. Shroff's study. One thing that she showed us all very importantly is that patients who have progressed on platinum-based therapy, their cancers have frankly grown on platinum-based therapy, despite the underlying BRCA mutation, those patients do not benefit from PARP inhibitor-based therapy because there's overlapping mechanisms of resistance. So that's one thing that we should try and avoid.
Yeah, I would agree. I think the preclinical data is really suggestive that cisplatin is better. But, when you look at the POLO study, the majority of patients received FOLFIRINOX. There was a handful of patients who received GemCis. Responses and such were equal for whatever anecdotal data that gives us. But, I would agree. I think we want to say one is better, but I don't know that we know that. So there's a question, just going back to some of the chemotherapy questions. So if somebody is started on FOLFIRINOX and develops significant diarrhea due to irinotecan, would you switch to gemcitabine and nab-paclitaxel or continue FOLFOX? Dr. Pishvaian, do you have comments on that?
I think this is a tricky one because I think dose adjustments can sometimes be made. I feel comfortable dropping down to FOLFOX, but I think it wouldn't be wrong to switch to the gem-nab-paclitaxel either. I think there's no wrong answer in this situation.
Yeah, I agree. I think it's like you said, between dose adjustments and supportive therapies, usually we're able to get the diarrhea relatively well controlled. But if I do need if the diarrhea is really dose limiting, I have a tendency to stay with 5-FU-based therapies rather than switching to gemcitabine and nab-paclitaxel. But, I don't think either way is wrong or right. And then there's a similar question kind of talking about sequencing. So if you start a patient on FOLFIRINOX and then give them gemcitabine and nab-paclitaxel, would you offer third-line Leary? And, for me, I have a general sense that while nanoliposomal irinotecan is obviously a novel type of irinotecan, my general feeling is that if they've progressed on FOLFIRINOX, which includes an irinotecan component to it, I would not expect a significant response to Leary. Dr. Pishvaian, do you have different thoughts on that?
No, I totally agree. And actually, thankfully, we're starting to get some data in this realm. There were 2 studies that were presented at ASCO GI asking that question about the benefit of Leary post-FOLFIRINOX. And essentially, it's what you said. These patients really didn't benefit, even though it was a new encapsulation of the irinotecan. So I generally wouldn't offer that for these patients.
Yeah. So we have a question here about patients with a DDR mutation, and do they respond well to anti-PD-1 therapy?
I hope so, because we have an ongoing study, what we're affectionately calling POLO-2, although that's not really the name of the study, but it's a maintenance study of olaparib with or without pembrolizumab for patients with known BRCA1 or BRCA2 or PALB2 mutations. There is definitely some really interesting science that the nature of the DNA mutations that occur in the setting of DDR mutations may make the cell more immunogenic and thus more responsive to an anti-PD-1 or anti-PD-L1 therapy. And we're starting to see some really promising results in other disease types, and there are trials ongoing in pancreatic cancer. But right now, we just have to say stay tuned.
Yeah. Yeah, I agree. I think that it's definitely intriguing that we think that these DDR patients have really the equivalent of an unstable genome, right? And so you would logically think that it would be a reasonable thing to think about. So then there's a question about, at this point, would you use maintenance PARP for a BRCA patient? And then there's kind of a second question that's a corollary, I think. So in patients with a good performance status, would you continue FOLFIRINOX or switch to PARP inhibitors after 16 weeks? So I feel very comfortable using maintenance therapy with a PARP inhibitor. Just like Dr. Pishvaian mentioned, while the OS was not a statistically significant improvement, I think there's a lot of complexity to that with the number of people that went on to subsequent PARP therapy. And I think there are other clinically meaningful endpoints that they saw in terms of, time to subsequent therapy and toxicities. And so what I always say is this is not breast cancer. I don't have 27 FDA approved drugs. So anything that I can do to kind of provide not only kind of control and or stability of disease, but also give patients a break if they've been on a pump for the minimum of 16 weeks, et cetera. I really think that it's a great option for patients. And like Dr. Pishvaian mentioned, with dose adjustments, I think we're able to keep them on it and still feel reasonably well. I don't know what your thoughts are about the question related to switching right at 16 weeks, Dr. Pishvaian, or do you kind of continue?
No, I like 4 months as a cutoff point, just because we know with oxaliplatin, whether it's colon cancer or gastric cancer or pancreatic cancer, it's right around that 4-month period that patients are really starting to feel the neuropathy. And so most patients are coming off the oxaliplatin or at least having significant dose reductions. So I've just made it my practice to stop at 4 months, with the exception of patients who are continuing to have dramatic benefit. In other words, their tumors are continuing to shrink on the FOLFIRINOX. Maybe I'll continue, but again, usually with lower doses of oxaliplatin. But as far as maintenance therapy goes, I agree with Dr. Shroff. I think that the benefits to being on a pill therapy with the appropriate dose reductions if needed are not, I don't think are captured adequately in the studies, because really these patients are freed from their pump and they can have prolonged stability for a long period of time, and then they're just taking pills.
Yeah, and I will point out that on the POLO study, it was a minimum of 16 weeks, right? So there was still a fair number of patients who were continued beyond 16 weeks, and perhaps just like Dr. Pishvaian mentioned, because they were doing well or to maximum benefit and things. And, it doesn't seem like that's a hard and fast cutoff in terms of when you can give PARP inhibition. But my bias is I typically tend to see that neuropathy setting in. And so I have a tendency to switch as well. And I think that's what most people I speak to, that's kind of what they seem to say.
Thank you very much, Dr. Pishvaian and Dr. Shroff. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, current and emerging clinical strategies for pancreatic cancer treatment, and to download slide sets associated with this discussion from the Clinical Care Options website, please click on the links in the show notes. As always, thanks for listening.